All right, hi everyone. My name is Josh Fox Fuller. Thanks for joining us for today's No Neuropsychology lecture. Just a few things before we get started. The No Neuropsychology Didactic Series is featuring a 12-week volume of lectures geared towards individuals across the training spectrum and professionals regarding clinical neuropsychology. And we have lectures on clinical disorders, professional development, practice issues, and research. The No Neuropsychology Didactic Series was formed by a team of early career individuals and trainees in neuropsychology. And we'd like to continue to thank our financial sponsors for support of our series. So a few disclaimers before we begin. This information contained in this webinar is not intended to serve as a replacement to the formal training of clinical neuropsychology, and the views of the speakers are entirely their own. Today, we'll be doing a moderated question and answer with the panelists at the end of the lecture. So please submit any questions that you have to the Q&A box, which will be directed to me at the end of the lecture. And if you have any trouble with audio, please shoot us a chat message. So without further ado, it's my pleasure to introduce Dr. Beatrice McDonald for today's lecture entitled Adapting to the Language Needs of Patients and Families in the Pediatric Clinical Setting. Dr. McDonald is a leader of inclusive excellence and a clinical neuropsychologist in the section of psychology at Texas Children's Hospital and an assistant professor in the Department of Pediatrics at Baylor College of Medicine. She's bilingual, speaking both Spanish and English, and deeply involved in developing and implementing programmatic systems and didactics that support cultural and linguistic equity and inclusion. She's served on several national and regional boards and initiatives that are focused on increasing healthcare equity, fostering mentorship, and strengthening the student pipeline. So with that, I'll go ahead and turn things over to Dr. McDonald, and she can go ahead and share her screens for us.
Thank you so much for the kind introduction and for the invitation. I've been following this program since it started with all of pandemic. So it's an honor and privilege to be here and to see some familiar faces as I was looking through the attendees. So thank you for attending, for the familiar faces and names. And for those who I don't know, thank you for making the time today to be part of this presentation. I'll be talking about, I know it got advertised as, working with interpreters, which we'll surely talk about that, but I think it speaks to a bigger, system, as Josh was mentioning. That is a big thing that I work on, is programmatic systems and changes, and really to adapt to the language needs of patients and families in pediatric clinical settings. And I've been doing this since graduate school and continue to do so as faculty at Texas Children's. So I'll talk a little bit about what we'll be doing today. So we'll definitely identify necessary processes, tools, knowledge to really prepare ourselves to conduct culturally informed assessments when it's considering the patient's background, language background, as well as the family's language. Describe the general principles and the limitations of using interpreters in clinical practice and how we can work around those and really integrate language services into our practice. As well as integrating language, habits, acculturation, academic specific questions relevant to understanding the patient's background, because at the end of the day, depending on where the family is coming from, we're very limited in the measures that we have pediatrically. So really thinking through that interview is going to give us so much information. So we'll start from there. And I know I was introduced, but I want to share that I have no commercial relationships to disclose. I acknowledge the traditional stewardship of the land where I work and where I live, and the people that have taken care of and keeping of these land and allowing us to be here today. And really positioning also myself as an individual. All right, so I'm Latina. I am from Guatemala. So I've lived in the United States for 20 years. So I've been on the medical system from being someone who was not learning, but practicing Spanish and figuring all of that out. So I've been on both sides, as well as serving and supporting my family when they seek medical care here. I am bilingual professionally, Spanish and English, and I'm trilingual. I learned Italian to be able to order and travel through Italy, which is one of my favorite countries in the world. I'm a mother, a wife, a daughter, a neuropsychologist. So lots of different roles that I'm going to speak through in this presentation, being not only a provider, but also being part of the system when we're seeking medical care with my family. And our outline for today, really thinking through ethical standards of practice, going back to the root of, sometimes in the practical and, adjusting to telemedicine and all these things, we just jump in and forget sometimes the ethical standards and our guiding principles. So let's go back to the foundation of what we need to consider when we're adapting to language needs of families in a pediatric setting, thinking through processes and tools beyond just the use of an interpreter to really support the family from when they're making a phone call all the way to receiving a report. And then the integration of language services from the hospital. So for pediatrics or private practice, right, depending on where you're delivering services, as well as, it's different when you work with adults versus kids in the terms of the language terminology, the background and understanding language development. So reviewing that literature as well. And then going into case studies, because as you'll see from my case studies, I've seen these in the last 6 months, but they're also very different. So really highlighting that it's, these are guidelines and considerations, and not everything that I'm saying might apply to where you are, but here are things that go through my mind and, in review with the literature as I've worked for the last, few years on how to really adapt and be inclusive when we have families coming from culturally and linguistically diverse backgrounds to our hospital. So first I want us to reflect and really think through what when working with an interpreter means for the family. So I want you to think about, have you ever been surrounded by people who spoke a language you did not understand? And they were talking about different things in front of you. Have you ever been unable to communicate directly with a medical provider about a concern you have, a concern a family member has, a symptom, and to really have the full understanding of the medical provider? Have you ever signed a document written in a language you do not read? Have you ever worried about calling to make a medical appointment due to lack of understanding, or who's going to pick up and how do I communicate that I need an appointment? Have you ever not understood the doctor's instructions or follow-up care to what your visit was about? And has a medical provider ever conducted a procedure you did not fully understand? I want you to sit with that and put ourselves on the situation our patients sometimes find themselves, the caregivers, the parents find themselves coming to see us at the hospital, at a private practice, wherever we practice. So in thinking that, let's go back to what anchors us in terms of our ethical standards. And Dr. Fuji did a wonderful job of summarizing this in his book. We need to test need to be in the client's language, right? Use of instruments. So think about that and what is our armamentarium of tests in neuropsychology. Tests need to be validated with the client's population, right? One of their APA standards are psychologists. Psychologists should be aware of test reference populations, right? Our understanding and going to the technical manuals of the measures that we're going to use to see, is the patient really represented, right? Is the child represented in that sample? Neuropsychologists should be aware of limitations of assessment practices and tests of cultural, including test bias, test fairness, and cultural equivalencies. Have we gone through the test population, if it's a nonverbal exam or test, have we really thought through that it's culture free, right? Where is the literature? Literature has lots of information about nonverbal tests not being fully free of culture, right? Neuropsychologists should avoid using interpreters who have dual relationships with a client, especially a family member, which could lead to either exploitation or loss of objectivity. I often have parents who's like, oh no, I'll interpret for my wife. I speak English. I'm like, nope, not. I want everybody to have a full understanding and not rely on for you to be fully present and for your wife, your partner to be fully present. Neuropsychologists ensure that interpreters are adequately trained and supervised to provide competent services, and we'll visit that more fully. If procedures are not explained, a client may feel disrespected and perceive the neuro doesn't value the relationship, right? So really ensuring the understanding of the patient, the family, that they know what we're doing, right? Not rushing through because now we have an interpreter and it's going to take longer for us to go through everything. So we're just going to rush through it and really taking the time. Informed consent. Consent must be understandable to the client and include consent, use the interpreter, right? So oftentimes we might not have the informed consent in the language of the family and they're signing a document that they don't fully understand or can read, right? So being very intentional in that and making everything, right? We'll talk about systems of having those consents in multiple languages. When interpreting tests, exercise critical judgment because situational, personal, linguistic, cultural differences may affect judgments and accuracy of interpretation. How certain are you, right? For the basis for your scientific judgment, how much can you rely on that data based on that thorough history you've obtained from the family? Data need to be sufficient to justify findings, right? But if you don't have a normative sample that represents the family, you did not administer in the language, you translate it online because, at the moment, because you were using an interpreter, are the data really sufficient to justify your findings, right? And then the limitations of data need to be documented, right? I've read countless reports where I'm not sure if an interpreter was used, but the family's bilingual, right? Or what norms were used, right? So really being intentional in documenting that because it's part of your case conceptualization, right? So really looking at our ethical and multicultural guidelines. The additional one is the culturally and linguistically appropriate service, right? Class standards from the Department of Health and Human Services for our hospitals. These were standards that came in 2000 to really improve the quality of services delivery and healthcare and reduce health disparities by increasing and achieving health equity. And really looking at the respecting our patients and the responsiveness and our responsibility as institutions, as private practices, to really respect the whole individual and respond to the individual's health needs and preferences. And for that, it goes beyond interpreter services. It goes into the governance, the leadership, and the workforce that you have in the organizations, right? And it being intentional to hire individuals, to train individuals, to prepare yourself, to have all the necessary processes in place to follow that principal standard, right? Provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. Right, so the patient and the family need to be able to fully understand, receive the materials in their language, right? Like that's the idea, but it's our standards of practice and how much are we actually doing that, right? So before going, I'm going to check in. Are there any questions, Josh or Annie, so far?
I don't think there are any questions yet, Dr. MacDonald, but I'll remind the audience that if they want to submit questions, we can do it at the end, or if you have these check-ins, we can do it then as well.
I'll check in throughout if there's questions as for each of the sections, but really thinking, right, these are our ethical guidelines and standards that we have. Are we actually doing them? Are we actually in institutions that are following them, that have the infrastructure? And, someone who's been in different hospitals from training and completing practica to, doing my internship, fellowship, and now being at Faculty of Texas Children's, it's different in each place, right? And definitely things to change, definitely things to improve, definitely things to highlight. So I'm going to think about, because once I graduated and completed fellowship, right, in our early career, going through and thinking, okay, like I still remember to this day, the first, we would complete, I'm going to go before this one, we would complete consent forms, right? And we had them in English and Spanish, and I would always request for an IEP from this school, and they would pre-sign a release of information. So it was always signed. They would do it in the office, the lobby. So it would always come signed to me. And I remember one day it wasn't signed, it wasn't in the packet. So I said, I was like, it was a Spanish speaking family. And I'm like, oh, like, wait a minute, I'm just going to go get the form, and going to the front desk and saying, where's the Spanish version? And they're like, oh, we don't have a Spanish one, we have an English one. And I'm like, but you're asking them to release medical information and you're having them sign in English. So we had all these forms, except the release of information was in English, because then the institution that was receiving it, and the rationale was, well, we're faxing it to the school, they're not going to read or understand Spanish, so we're not going to fax the Spanish one. So I was thinking through that. I'm like, okay, how do we make that process more effective, right? So we had a release of information in Spanish, and when you faxed it in Spanish, you sent the copy of the translation of what it was in English, right? It wasn't signed, but it was, here's the translation of the document that I'm sending you. Please send us the IEP or the school services forms, right? But it took, it was years of practice of like, well, this is what we do because the school is, but it was going back to the intentionality. So little by little, all of those things, with Dr. Adriana Strutt from Baylor College of Medicine, we really thought through, okay, it's not just using interpreters, it's not just going to the literature, it's really a model of a system of practice, right? So I'm not going to go through this model. As you can see, it's very, it has components, and each component has different elements, but you can see here under consultation and collaboration, we have interpreter services. We have the clinical application, but you're also training on clinical services and really going through the literature and education and training, right? So today, there's different components, but I'll focus on consultation and application and those processes. So, when we're thinking about clinical application and integration, we're really looking at that intersection of clinical practice and our sociocultural factors. So, from A to Z, from making that phone call to receiving that report, how is a family interacting with the system, and how are we providing those supports? What are our day-to-day practices, and are we able to provide access that is equitable and inclusive to all our families based on what we have? And in order to do so, there's lots of different moving pieces, right? We have interpreter service, and it's the collaboration with other pieces of, the hospital or private practice with contracting, right? Interpreter services, and a national and international, getting teaching and research and consultation. And really, the consultation is going to be key because I have a lot of experience working with Spanish speakers and a lot of work with Latin American countries and the Caribbean, but I recently worked with a family that was from Iraq, and it was an Arabic interpreter, and I'm like, well, this is a whole new area for me, so let's go back to consulting and collaborating and working with interpreter services. So it'll be one of the cases that I talk about today, but it is really looking at our practice as well as our collaborations within the hospital, because that's going to give us our tools and processes, right? We need to hire multilingual staff and providers. So for us at the hospital, if you're a Spanish speaking provider, most, like my scheduler, for example, speaks Spanish. Most of our schedulers speak Spanish. So from the moment that you're making that phone call, you're able to connect with the scheduler. If you speak another language, a phone interpreter will immediately come in and be able to provide support through that conversation, right? Our forms and our questionnaires are in multiple languages. Our 3 top languages are English, Spanish, and Arabic. So our HIPAA and all of that information is in Arabic. We're going through different phases. So now we have all our forms, of course, in English. We have all our forms and questionnaires in Spanish. And then the next step is Arabic, but it is the budgetary responsibility of the hospital, right? So there's things, in phases of how we're doing our quality improvement projects. We have audio, video, and in-person interpreters. And with all of COVID budgets and everything, some of our in-person interpreters got suspended. So we really learned to use our Stratus machine, which is, this little iPad that you move around, and it gives you access to interpreters of any language, right? So really working and adapting to that. We have translation services for documentation. So that's a partnership with language services, and then partnerships again with the international office to be able to work with them for families seeking services here from other countries, or language services and speech and language services as well. So I consult and mentor individuals that are early career or graduate students or fellows that are providing culturally and linguistically diverse services nationally and internationally. And one of the partnerships that's been very fruitful has been with language services, speech and language therapy and services. So doing that language evaluation before they do neuropsychology to have a better understanding of the language background of children, of the child before they're doing their testing. Processes, I think scheduling is a big one. When we do have, for example, bilingual psychometrist, or have individuals, interpreters, we've had situations where if you don't organize your schedule of who you're going to schedule, you might end up with 3 Spanish-speaking patients on the same day and not being able to then provide the same quality of care because of interpreters, bilingual psychometrists, or bilingual providers. So really thinking through, I've now worked in 2 different practices where there are designated Spanish slots for families because 20% of our patients are Spanish speaking, and really being intentional on how they're scheduled. That doesn't mean that they'll be longer, but organizing so that the processes are in place for better and higher quality of care that is provided. We have a process for requesting interpreters, so there's a system in place for that as well. And then neuropsychological measures that are purchased, right? So we do have one that is in English and Arabic. We have lots in Spanish, and we go through and update our measures. So really looking at that as well. So our tools and processes are important because that is going to be making our interactions with interpreters and the services we can provide through that easier. And before I move through that, in terms of tools and processes, any questions or any thing to highlight?
I don't think we have any questions yet, but yeah, I'll chime in at the pause points.
Perfect.
Yeah.
Thanks, Josh. So in thinking through, how do we then integrate language services and how do we do this effectively? We're looking at service delivery and training, right? And we really have to go back on where our field is and what we can do as neuropsychologists. So in 2014, we got surveyed, and about 412 doctor level psychologists from INS and NAN from US and Canada responded. 91 of the neuropsychologists identified as white, non-Hispanic. Caseloads, 60% of the individuals were white, non-Hispanic, and 72%, which was higher from previous surveys, received training in neuropsychological assessment of ethnic and racial minority populations. Where they had received their training varied, as well as the type of didactics that they had varied. But I think the stark note is that 17% of neuropsychologists were able to conduct evaluations in 2 languages. Right. So it really looks through, okay, who's going to be doing this work? Who is going to be, with the changing demographic of the United States? And it's not only Spanish, but other languages, who is being trained, right? And what are the obstacles, right? So, when asked if a patient seeking neuropsychological assessment is not fluent in English, what follows? 69 would refer to a fluent neuropsychologist. However, with 17%, we're going to have a very long wait list, right? So part of it is also the responsibility of diversifying our field and being prepared and having that infrastructure to be able to then provide these services, right? It's not just the interpreters, it's all the processes in place and the intentionality that goes behind that and the consistency of that within the system and the structure. 41% use an interpreter, 27 use nonverbal tests, but we've talked about that also having its drawbacks. 10% use of bilingual technician or psychometrist, which, that can be definitely increased. And 5% administered measures in the appropriate language. That is a scary one, right? Because then we're thinking through, okay, if it's Spanish, there's lots of different measures, right? So we definitely are able to do that. Other languages is more difficult, but with adults, there's papers coming out of different batteries for different languages in adults. It's more limited, unfortunately, in kids, as well as the number of bilingual providers in children is even smaller. So, things to keep in mind as all the challenges, that we are all well versed and well aware of. But, it goes with the highlighting that, for example, we can't put then the minority tax or the minority responsibility on the bilingual providers to do all the testing. So for example, I don't see all Spanish speaking, like my caseload is not all Spanish speakers. 50% of my caseload are Spanish speakers, and then there is a distribution of who sees Spanish speakers. I am a consultant for a lot of the cases, but we have the measures, we have bilingual psychometrists, we have, again, the infrastructure then supports the provider to be able to provide those services. And then when we're looking at language services, right? So what are we going to be doing? And we go back to use of interpreters. We have translators versus interpreters that oftentimes people use interchangeably, but they're not. Interpreters is live interpretation when you are speaking, and translator is of written documentation, right? And you can have proximate in person versus remote audio and audio visual as well. And this one is one that even with, we talked about the APA standards of formal training of interpreters. And we often think, okay, we're using interpreters, we're good. But untrained interpreters in a medical setting, in the 2005, misinterpreted or omitted up to 50% of the physician's questions in a medical setting. And then when we train them, it's better when they're trained, absolutely, but they still make errors. And in a pediatric emergency department, there were Spanish language interpreters made an average of 31 errors per patient. And of those 31 errors, 67% potentially impacted diagnosis and treatment. So things to keep in mind. And I think one of the models that I use with my trainees, and I often get asked, it's like, isn't it tiring to be you serve as the interpreter? So I'm a dual language provider. I'm not a certified interpreter. And I explain that to families. And I say, we can have a certified interpreter, or I can be the one interpreting and being able to go back and forth. Most of the time they select me as an interpreter. It reduces the number of voices in the room. And I'm assuring, right, because I have a bigger clinical background, right? But that there are other providers that are very strict about having certified interpreters. So that is, it's different practices, but I think it also taking into account the errors is something for the model that I use in training both bilingual and English speakers in the delivery of services for bilingual Spanish English patients. But I think the general principles that we go through, even when I'm an interpreter or use an interpreter, is having a pre-session. That is something that in clinical psychology we do, as well as in neuropsychology at the hospital. And it's really important and helpful to give context to the interpreter, even if it's, audio, video. You can have them on the video, explain what the situation is, what we're going to be asking, give context. Through the session, there might be pauses. I've had colleagues that are doing, interpreters via Zoom, and they might pause and move the patient to the waiting room and then have a conversation with the interpreter and then bring back, right? And definitely the post-session, we are clinical psychologists and neuropsychologists, right, in terms of our training and working with different medical conditions and how it can impact kids and families. But I've definitely had interpreters tear up, right? So I think the post-session for the interpreters in terms of language usage, all of that information is important, as well as processing with them. And I think that is also very important to review consent and confidentiality with the interpreters. Oftentimes when it's audio video, they review consent immediately as you're signing on through the service on like Stratus or whatever company or equipment used. But it's something that we need to remind ourselves to do when we're doing an in-person interpreter, right? Asking their certification, documenting that, and I'll cover that on the next slide. But we need to document all of that in our reports, right? If there was an interpreter used, the name of the interpreter, were they certified? What are their qualifications? The interpretation or the translation process used. Was it simultaneous? Was it, who was the one benefiting from the translation in the situation, as well as, discussing what observations to document especially, for example, there was any code switching between languages or any grammatical errors or all of that information, right? So they are the ones observing that quality of the language for the patient or for the child. So giving that information, and oftentimes we'll have it printed out for the interpreter so that they don't have to either they'll be taking notes or we'll give notes of like, these are the things to please keep in mind when you're testing. If they're going to be administering any or helping, they're the extra hand or the voice, right? The familiarity with the instruments, and looking, especially if there's language, we'll talk a little bit about that in a little bit, but language measures, right? What is it, a valid administration? And by saying the word, are you defining the word, right? And having those candid conversations with the interpreters beforehand. And it's helpful to include all of this, the terms of quality of the interpretation, the interactions that the interpreter had with the patient, identifying possible sources of error and potential, like documenting all of that, right? Because when we're asked, is it a valid assessment, that is going to be part of that validity, right? Because there was a use of an interpreter. Because research on the use of interpreters highlights that. Dr. Casas in 2012 did an interpreter-mediated neuropsychological testing of monolingual Spanish speakers. And I love her study. It was 40 neurological normal Spanish speakers with limited English proficiency, and it was counterbalanced. So both completed the vocabulary similarities, block design, and matrix reasoning with and without an interpreter. So it was the same person with counterbalance. And what they found was, when you look at block design and matrix reasoning with and without an interpreter, there wasn't a significant difference, right? So that was maintained. However, similarities and vocabulary was significantly different, especially vocabulary, as you can see from the means and the standard deviation. So something to keep in mind when you're then interpreting, right? Language measures, nonverbal measures are still culture dependent, as research has shown from Dr. Rosselli, Dr. Ardila, and the literature. But similarities, the verbal ones are definitely more influenced, especially if it's not a translated already measure and you're doing the online translation. So in order to, we've reviewed the research on interpreters, the use of interpreters, right? So what are quality improvement projects that you can do when you're working with interpreters or language services? There are things, using an interpreter for one patient, that's one thing, right? But if you're going to be serving individuals from different backgrounds and different languages, you have to really think through how your delivery of care is inclusive. And one of the projects that we did at University of New Mexico with Dr. Elias and colleagues in 2020 that was published was really looking at the implementation of recommendations, right? Our reports are the most important thing that we do at the end of the day. So what is actually being implemented? So when we looked at that, there were about 52% of all recommendations of our reports were implemented. So think about that when we're writing, 16 or 17 recommendations. And then results, indicated that there were lower recommendation implementation for households with lower income. However, language was not an issue because at University of New Mexico, a summary of the evaluation and a list of the recommendations in the family's language are provided. So if you give the tools to the family in their language, they are going to implement the same amount of recommendations on average as their English speaking counterparts and monolingual family members. So the reasons for not implementing, was lack of time or lack of resource, ambivalent about the need to implement the recommendation, remembering the recommendation, confusion about how to implement the recommendation, and resistance from schools and teachers. So thinking about confusion or remembering, right? In a feedback session, the family is getting all this information. There's an interpreter, right? So think about ways in your system to make recommendations something that is written, right? So when we surveyed our faculty at Texas Children's at different time points, the principal, like always, request was and is to provide recommendations in Spanish and other languages. So we've actually started a quality improvement project where the faculty submit their recommendations. We work and partner, again, that partnership and consultation with language services, and we are translating those recommendations and building a recommendation bank so that when you're writing a report, you can put copy paste or, smart phrase if you're using an electronic medical record, put in the recommendations, English and Spanish, for families to be provided, as well as, then translating the report or a summary. There's some hospitals around the country that do translate the whole report. Others do a summary and recommendation. So depending on, what the capability of the institution is, that's what they're doing. Looking and being intentional about finding resources for families in their languages. As well as we have another quality improvement project of brief translation messages, right? Sometimes even just scheduling an appointment, right? Do we send the message in English? Does it get translated to the family? So we've have a project of, you submit your message within 24 hours, it gets translated by language services, and you're able to send the family their message in Spanish for communication, right? So through medical record communication or for privacy and HIPAA protection or PHI information. So lots of different things to think about when providing services. So I'm going to pause there.
Yeah, I think we have a couple of questions that popped up, so maybe we can talk about these now. The first one, which kind of ties in more with the specific section, because I think the other one refers to the prior section. What level of training in language services is required for bilingual psychometrists? Or what would you recommend?
Oh, that's great. Great question. So there is a lot of variability, right? Because they're not in the same, some hospitals have all certified interpreters, right? But then the psychological associate might not be. So it depends on then who's doing the hiring. There's very variable. So I've definitely interviewed, psychometrists who were not bilingual. So I think there has to be a way and a parameter for when you're hiring to be able to determine that. That you can become a certified bilingual psychometrist. So I've worked with individuals that have gone through that process as well. But there's a lot of variability. So you have to, and I have a lot of variability even in individuals in our current practice, right? I have someone who is from another country and Spanish is their native language. Other, it's, they learn Spanish and have some understanding, right? So it depends on also who you're pairing that patient with as well. So there is variability, and there is in the hiring. My recommendation would be in the hiring process, if that is your intention of hiring someone who's bilingual, to have a process on how you're going to test for bilingualism. For example, for me to provide services in the hospital as a dual language provider, I have to pass a test. And all our our psychometrists needed to pass a test as well to provide those services. So it can be as part of the system or as part of your practice to formalize that process.
Great. Thank you for that answer. I think that's a very thorough answer that just have different pathways that people could choose from depending on the situation and needs of the institution. This next question, maybe, I don't know if it ties in with the last part of your talk. I know we have about 20 minutes left. It seems, I would assume probably the answer is a little bit more about your narrative and your personal story, because it's talking about how, so the question is basically, how did your team establish the relationships with speech and language? How did you present this rationale to referring providers? And, like, for example, did you have discussions with the hospital, or what was that like? So I'm not sure if you want to address that now, or if you think that's going to come up kind of later.
It won't come up later, but I will talk about this. So we've part of developing the Salud model was really coming in as one of, for a period of time, it was the co-director of inclusive excellence. And then we have an inclusive excellence now executive steering team. So we have a really strong division with diversity, equity, and inclusion at its center, and very much infused in training, research, and clinical practice. So part of my hiring and part of like the work that I've done in other programs is looking at the system and really partnering with other individuals so you're not duplicating. So it's conversations, it's building collaboration. So it's really that consultation and collaboration that is really important to be able, because you don't want to be doing the work in a silo. But it's intentional. And sometimes you get more resistance depending on what leaders there are, and you have to wait. Others, there's more momentum and you hit the ground running. But it's really engaging in those conversations. And I'm usually the one always bringing it up. But as my family says, I'm the one getting paid for that. And in terms of building that inclusive approach for healthcare and increasing equity.
Great, thank you so much for answering that.
And then in terms of pediatrics, I'll go through, because I want to go through our cases as well, is, our bilingual children and children that don't speak English, because of the measures we have, they're at a risk of being misidentified, either with a language disorder or a learning disability, or having a learning disability and saying it's like, nope, they're learning English and that's why they're struggling at school. You can be learning English and struggling at school at the same time. But because generally a language disorder is diagnosed when significant difficulties are seen in both languages. So really thinking about when you're working with kids, we have the additional language development consideration, right? And that needs to be really integrated in all that clinical interview, because sometimes we're not going to have the measures that we need to test. So we really need to look through what the language development's been, social interactions, and really be thoughtful in the culture and what we're gathering in interview. So I wanted to put this slide. I know it's recorded so you can go back, but think about what questions you're asking to really include the family, their background, and their language, because you're going to be looking at what languages are spoken in the home. I think the one that always gives me the answer is like, if a parent asks a question in home language, in what language does the patient respond? That's pretty telling, to think about the level of proficiency of the child. So that question I always ask, in what languages are the child reading and writing? Because that's then going to inform our clinical selection of battery. How well do they speak the home language, social media, music, television, social interaction? So I have a system that I go through all the questions to really inform. And one of the things that I love about telemedicine and, one of the gifts from all what we've lived through this last 2 years is now I do my clinical history via telemedicine before the child comes in to practice, and I'm able to get all of this language history beforehand to really have an informed battery on the day of testing. For example, I was meeting with my team today and the family's bilingual. We are doing interview and day of testing at the same time, and we don't have a lot of information. So all of that's going to be gathered at the beginning and then inform and like think on the fly and select batteries. So I was realizing how spoiled I was from, having the majority of patients doing their clinical interview beforehand. Here's a reference for the list of practical recommendations, right? When you're thinking through of all the things that we're going through, right? Obtaining a comprehensive history of language, gathering specific questions about the school enrollment and education, conducting standardized language proficiency testing. So really thinking about what measurements you have, especially in Spanish, that are more available than other languages, right? Evaluating language function. I work a lot with children with epilepsy. So when it's pre-surgical, language is very important to assess. So being comprehensive on the testing, because language development in bilingualism, or, when you have a lot of, children are different than adults in terms of a lot immigrate and they are speaking Spanish, but now they're going into school, so they're going to be exposed to English, and it ends up being more bilingual regardless of what the home language is. So thinking about basic interpersonal communication versus academic language and how long it takes, because that's going to really inform what measures you're selecting to test, and really think about what is their language development specifically in English, and if you can test it in Spanish or the other language, that's amazing as well. But holding it in context of language development is really important. because you can, develop basic interpersonal communication. It takes about 2 to 3 years to develop. That's very different than cognitive academic language. Fully developed may take like 7 to 10 years. So if someone was hearing Arabic or English or Spanish for 5 years and their kindergarten is going to take up until they're 12 to really have solid cognitive academic language, versus, they're speaking English, right? Because they've been learning it for the last 2 to 3 years in school. They're 8, so they're, have basic interpersonal communication in English and Spanish. So really thinking through that when you're explaining language functioning, when you're interpreting the data, and when you are selecting measurements. As well as the other concept of limited bilingualism when you're looking at more limitation of language. So what language should be used for the evaluation really is dictated by the referral question, right? So does the bilingual child have a language disorder? It should be ideally in both English and Spanish, right? If that is the language of the family. How will this child perform in a mainstream classroom? So if they've immigrated and they speak Arabic, this evaluation, can be conducted in English if that's the language of instruction that's going to be in school, and really then being able to compare, okay, if I don't have measures in Arabic, then how is their home language and how is the interactions at home, and really be able to compare. So, thinking through that, be able to incorporate. So I'm going to talk about one of the case studies here. Here it's different, right? It's a bilingual Spanish-English, provider working with a family that speaks English and Spanish. My trainee is English speaking, right? The child is 9 years of age, right-handed, Latino male with a medical history of absence epilepsy. We have all the forms and questionnaires are in our schedulers. We have a bilingual staff. So the experience of the family is very different from other families. And we were able to gather all the information in the history and talk about Spanish and English, like speaking and language. So the home language is Spanish, the family's from Mexico, academic instruction in English starting at 4 years of age. So now we're thinking, okay, they've been now 5 years, they're gaining more cognitive academic fluency, but probably have strong basic interpersonal language. Answers to his parents are in Spanish, so looks like probably a little bit more balanced or fluent in both. And his social interactions are in both languages, right? So it's giving me that, this child is using both English and Spanish. Probably we're gonna have a variety of measurements that we have available. So I'm wanting to see, how is he constructing sentences with the self and formulated sentences in both languages? If all of the academic instruction is in English, I'm probably going to do a WISC in English at age 9. With some supplements in Spanish if needed. I'm going to do confrontational naming and receptive vocabulary, depending on the measures that I have. So I'm looking at single vocabulary. I'm looking at basic conversational language in both languages, and then academic language in English, and testing academics in English, right? So really thinking through, okay, what's the process? What's the language? What are the measures, right? And as a bilingual provider, I'm the one that's doing, the feedback and the interview, and I serve as the interpreter, right? So there's a little bit more protection in that. In terms of errors, that was different in this recent case where it was I don't speak Arabic, so non-Arabic speaking providers with Arabic English interpreter, 10-year-old right-handed female from Iraq, and really was important to prepare with the Arabic interpreter when we did the diagnostic interview. We were doing diagnostic interview and day of testing at the same time. My interpreter no-showed. So we had to do Stratus, and it had to be an audio video interpreter. Thankfully, it was a wonderful interpreter. So we did a little bit of preparation about the questions and the language, and we wanted to get, and it was about an hour and a half interview, got lots of information. Mom was a great reporter. Medical history of epilepsy with difficulties of medication adherence. Because, and we talked about it, it was not the refusal, but it was the understanding of epilepsy and the acceptance of epilepsy for cultural reasons. So we had that conversation with Mom as well. They had immigrated at 3 years of age and then started learning English at 4 years of age. So now she's had 6 years of English of learning and conversational. She served often, our little patient was often mom's interpreter in the community. But mom noted difficulties in both English and Arabic. And we unfortunately did not have forms and questionnaires available in Arabic. We had one form, and we used the interpreter to be able to guide mom with all the questions, and selected key questionnaires and read them through with the interpreter. Again, that's not how our, the BASC or the brief were normed, but being able to document that in the report. We only had one measure that was on confrontational naming, and it had its limitations because it's formal academic Arabic versus more conversational, so limitation on that. And it limited our interpretation of results. The language measures in English were very not low, but more in the borderline, right? 75s, 70s. And her nonverbal abilities were higher, right? Low average, low end of the average range. So really thinking through, there was no premorbid before the epilepsy onset at age, I believe the age onset was 4. There was no developmental concern. So really thinking through, okay, this is language development, being impacted by epilepsy. So really thinking through. One of the things that we did for the feedback preparation and delivery was go through bullet by bullet of everything that was going to be said to pace. We talked with the interpreter, we debriefed before and after, and it was a very emotional feedback. Our interpreter teared up, and mom teared up, and so it comes to show that when done intentionally with empathy, with understanding, with responsiveness and care, even if we're using an interpreter, you can connect with the family and really be able to deliver high quality of care. So of course our evaluation has limitations, but there are services and therapies that are going to be recommended, and we will continue to reassess and reevaluate this patient for convergence of evidence. So I'm going to skip that third case, and then I'm going to take home points. We need to diversify the field. It is imperative, as highlighted, to know your limitations and to then grow and take them as opportunities for growth and understanding, and gain more knowledge. Think about tools and processes beyond interpreters. Integrate language services into your clinical practice, depending on where you are. Prepare yourself, prepare your interpreters, document in the report, and consult. As I said, reach out to colleagues within your service as well as outside of your service, to really, that's the name of the game when we're working with oftentimes not having the necessary assessments, and how are others doing it, and how it's working out nationally as well. Okay. Thank you so much.
Great. Thank you so much, Dr. McDonald, for that excellent presentation. There's one question in our Q&A, and I think I might have a question as well, but if anyone has any questions as we conclude, I invite you to submit them to the Q&A box. So this question, basically the individual says that they really appreciate you highlighting the potential tendency to put the sole responsibility onto providers who speak other languages to do these assessments, which I think is a critical issue that our field faces for sure. Obviously there are ethical decisions at play, right, of wanting to, refer to somebody who competently could conduct the evaluation. But ultimately it creates more work for individuals who are bilingual or who understand that culture and that scenario as well. So the question is, how do you build balance into your schedule, or how might early careers set these boundaries within their own institutions of creating space, kind of like yourself? You mentioned that you don't only serve Spanish speaking patients, of course. So what are your recommendations around that?
No, absolutely. And I think it's such a delicate piece, right? Because we've been taught to refer to, a bilingual provider, but as you saw from the percentage, right, we've not diversified our field, and it has to until we are able to balance that out, it can't rely always, right? I, for the longest time in New Mexico, was the only bilingual pediatric neuropsychologist. So all the responsibility couldn't fall on me, right? So I think it's in training. And I am so thankful for one of my mentors, right? Because as an early career professional, I was like, of course I'll see all the Spanish speakers. And he was like, absolutely not. Think about board certification, think about, straightforward cases, think about your time and your balance, and cases take longer because I write also a report in Spanish. So I'll do the summary and recommendations prior. It's just easier for me. So it takes longer. Those evaluations take longer. And I've had to be in uncomfortable meetings saying, no, it is not my responsibility. You have to also be trained and practice. I'm happy to consult. But I think it's one of those things in early career of boundaries and really holding. So I get the complicated ones, right? So I take often, for example, in epilepsy surgery, the like very high functioning bilingual individuals that they're really going to need a thorough understanding. So we've reached the happy medium, right? Where I get certain cases versus, intellectual disability or someone who's nonverbal. So, but it's through conversations and through really explaining that it's I can't keep up then with reports, right? And having that honest conversation. So I think that's, a lot of my answers have been, right? It's in collaboration, it's in conversation to be able to partner with others and to balance out your schedule.
Sure. So we just, there's no more questions in the Q&A box, but I have one, just to maybe as our last question. So I know you're very strong champion and advocate of diversifying the pipeline, and not only diversifying the pipeline, but creating or basically removing traumatic or trying to eliminate traumas throughout the pipeline process that people experience in training. So I'm just curious for this maybe last question, if you can talk briefly about some of those initiatives that you're involved with or what people can do to be involved with, continue to diversify the field. Again, not that those individuals need to serve their communities per se, but that's the only way we're going to, continue to grow. So
no, absolutely. Thank you. I think mentoring is one of the initiatives that I've been closely involved. So through the Ethnic and Minority Affairs Committee from Division 40 and mentoring. So as well as the Hispanic Neuropsychological Society and the Houston Neuropsychological Society. So I've served on those three boards and committees for the mentoring programs, and it keeps coming up, right? So it's a lot of consulting on how to put together your application, how to put together. So it goes back to the nuts and bolts of just, helping and supporting through that process. And I love your question because that was something that I was actually reflecting. Someone I think on Facebook recently posted of a university that had a program that's going into high schools and going into college to talk about neuropsychology to underrepresented groups. So I think it goes all the way to that point because I'm like, okay, we're talking about already individuals in graduate school. That's great, but we need to go even further like down the line in terms of, so that's what I've been thinking through this weekend as I was typing this and, looking through, it's like, what programs can we create? What programs can Texas Children's, can Baylor College of Medicine, can national organizations create? Because it is great to do the mentoring, but I think we have to take it to the high schools. We have to take it to younger ages.
I think even international as well. As someone who mentor, like for example, one of my mentees as an undergrad is from Turkey, and they're not super familiar. She wasn't familiar with the practice of neuropsychology there, and her parents are neurologists. So it's interesting too, kind of thinking globally about it as well. But yeah, I definitely think the mentoring piece is really great, and I'm excited to hear about all that work you're doing. So thank you so much, Dr. McDonald, for your presentation today. Just quickly before we end the webinar, I just want to note that next week we do have another No Neuropsychology talk. We're coming to the end of our 4th volume, just a couple more lectures to round this out. But next week we'll have a panel discussion at 3 p.m. Eastern time on work-life integration featuring Dr. Dean and Dr. Boxley. So you won't want to miss that at 3 p.m. Eastern next week on Monday. Thank you again, Dr. MacDonald, for your presentation. I look forward to chatting with you and seeing you around, hopefully in person soon. Bye,
Thank you
everyone.
so much. Thank you so
Yeah,
much, Doug. Thank you so much, Annie. And thank you so much for the audience. I really appreciate you taking the time and space.
you bet. Thank you.